This is a remote transmission for an Abbott single chamber ICD. This is the Fortify Assura 1357040Q. We can see that this came in on December 6th of 2020. The device was implanted June 18th of 2019, and we can see that the auto capture is not on. It looks like the last test was run September 27th of 2019, and these are just some auto test measurements that came in. So it looks like this transmission came in because there were episodes with alert conditions. And we can see right here under the VTVF episode since November 30th of 2020, and remember this was just 6 days past. This transmission came in 6 days after that, I'm sorry. There were 11 total device diagnosed VTVF episodes. So if we break that down, it is classifying 4 of them as non-sustained episodes. That means they did not meet detection. It is saying there were 4 VT1 episodes, and then there were 3 device diagnosed SVT. So we'll get more into this while we talk about this interrogation, but just know that this is why this transmission came through. This is our episode summary slide. So this again is showing that the episodes were last cleared on November 30th and last read on the date of this transmission, which is December 6th of 2020. It breaks down again any sort of therapies that had been delivered. So we can see here that even though the device detected 11 episodes, there were no therapies delivered on any of these recordings. On your episode tree, this is just going to break down based on the programmed detection zones where these episodes fall. And you can see that these all fall into the VT1, which is just a monitor zone. So it's important to know that in this particular patient, this monitor zone is programmed, meaning it will just record episodes that fall into that rate branch, but it will not deliver therapy. It's just going to be watching them. So it breaks it down here. Again, we can see that there were 4 non-sustained, meaning that they did not meet detection, so discriminators were not applied to them. There were 3 diagnosed as SVT episodes, and then there were 4 diagnosed as VT. So if we break this down a little bit further, this is going to give us the date and the time of these episodes. So we can see that the majority of these all happened on December 4th and all about the same time. So it looks like it kind of started at about 4:06 p.m. They had another one at 4:08. 4:09, 4:10, and then it kind of ends around 5:25. And then the next day, it looks like there's one around 9:15 a.m. If we take a look at the average rates here, the fastest is this 162 beat per minute episode, and it's actually the longest as well at 5 minutes 6 seconds. So again, these are all falling into monitor only, but we do have alerts associated with them. And it's most likely because of the duration and also dependent on what the discriminators that were applied determine. This next page of this report is just a diagnostic summary. Again, this is a single chamber ICD, so most likely implanted for primary prevention, just kind of as basically a shock box. And if you remember on the first page of the interrogation, it showed that the rate was 40. So this patient is not pacing at all. It's less than 1%. That's been consistent with the lifetime of the device. So we are V-sensed greater than 99% of the time. This is still going to give you a rate distribution, just so you can see that this patient pretty much is rate controlled. So just another diagnostic summary there to take a look at. This part of the transmission is just our MRI settings summary or MRI summary report, given that devices and wires are being retroactively labeled for MRI safety or compatibility. These may change, but basically it's just saying that our current parameter for a patient going into an MRI, tachytherapy is currently enabled, but during an MRI it would be disabled. So these are all programmable. I haven't seen offices do this on their own, but just pointing it out so you know that this is there. This slide just shows the alert summary, so why the transmission was sent. I think we pretty much figured it out earlier on, but there were episodes with alert conditions, which we will see on the breakdown, and that there were VT-VF episodes that occurred. So we will dig into that a little bit further. So this is our freeze capture. This is just what's going on at the time that this transmission came through. So I always say that single chamber devices are either the easiest or the hardest to interrogate. It's because we are just looking at one lead. So if we take a look at this rhythm, we can tell that it's all V-sense. We know that it's intrinsic, but we don't have the luxury of having that atrial lead to see what the sinus node is doing. So this looks super regular. I cannot decipher P waves in here. So if I were to be writing up this report, I would probably just write VS at and whatever the rate is. So it's approximately 750 milliseconds. So right around 80 beats per minute. The next part of the report is just the extended episodes data. So again, it's just giving you episodes last cleared, when the device was last read, the therapy summary. So again, we see all zeros in here, meaning that there were not any therapies delivered during any of these recordings. Again, that's because it's in the monitor zone. But it will also tell you what the results, if the device had given therapy, what the result of the therapy was. So in this case, we're looking at ATP. Even though there were no ATP sequences delivered, it would break it down if ATP was successful by terminating a rhythm, if it was not terminated, and then if it were to actually accelerate the rhythm into VF. We do have ATP while charging for the VF zone, so it's just one last attempt while that device is charging up in the fib zone, just in case it's a fast VT. Just do a quick pace sequence, and if that's enough to terminate the rhythm, then the shot can be aborted. So we do have that feature on the Abbott VF zone ATP while charging. Again, not relative with this particular transmission because there were no therapies delivered. Click forward here. So again, more extended episodes, that episode tree again, just breaking everything down. This is the SVT diagnostic summary, the discrimination criteria. This is all programmable. This is done at implant typically. I mean, obviously we need to sometimes make some changes depending on recordings and therapies and just patient status, but this just breaks down in extensive detail what the discriminators are seeing. Let me click here. And this is, again, the extended episodes tab. We saw this earlier, just breaking down the date and the time, the rate, any sort of therapies that were delivered, and the alerts associated with this. It also records a morphology template update. This is just going to tell you how the device is scoring a normal sinus rhythm or normal ventricular rhythm morphology, that complex of an intrinsic R wave. So that way, when there is a fast rhythm going on that meets detection and discriminators need to be applied, you will have an active, updated template to compare with the rhythm that's happening, and that is all part of determining if the device is going to deliver therapy or not. So we will look at some of the episodes that were actually recorded. We're going to get a nice summary page, and we can see here is episode 1 of 11. There are 6 pages for this one. It's going to tell us the duration of the episode, the time. So we can see that it was 4:06 p.m. It was 2 minutes, 18 seconds. Again, we're getting that alert because the duration of this episode was over 1 minute. Diagnostic summary. So this is telling us that all the discriminators agreed that this particular rhythm met detection. The device applied discriminators to it, and all 3 of the discriminators are telling us that this rhythm is SVT. SVT is not a shockable rhythm. Again, though, this particular zone is monitor only, so it wouldn't deliver a shock anyway, but it is kind of nice just to get this breakout talking about what this rhythm appears to be, even though it's in the monitor zone. So I can actually show you the here. So the vSense amp is what the device sees. So that's going to be the bipolar signal on the RV lead. And then your discrimination channel is going to be your far field channel. So your sense amp is going to be your near field. Your discrimination is going to be your far field. So this is done by looking at the RV coil to the can. And then it can compare these 2 different vectors to see if they're basically matching up and seeing the same thing. So that's what a discrimination channel is. So we can also see here on the markers, it is binning these as a vSense. T1 means it's falling into that first bucket of rate. So the tachytherapy is 1. When you see a little check mark, that means that the morphology of this beat matches SVT. So a normal, it matches the intrinsic morphology. If you see an X, it means that this morphology does not match that template that the device has been consistently updating in order to compare a fast beat to what a normal beat looks like when the rate has not been detected for one of these zones. So we can just kind of follow along. You can see how it's kind of binning it. And then it's just saying, yep, this is SVT. It's applying discriminators. This got a little muffled on the transfer over to PowerPoint, but we can also see that there is some variability in this rate. So we can see like 414 milliseconds, 355, 379, kind of, bouncing all over the place. This doesn't look like VT to me. It looks pretty narrow. And if I'm comparing these to the ones that have also been recorded, I agree with the device. I don't think this is VT. I'm obviously not a physician, but if I saw something like this, it looks like supraventricular tachycardia. Again, we are not here to diagnose, but I do like to compare the episodes, and you do start to recognize rhythms, especially when you're used to seeing them for patients that you follow routinely. So let me see here. So this is just, recording. This is just a break in the recording. I mean, it's still there. I believe this is called a stitch, but because it was a longer recording over 5 minutes, it just is a way to kind of compress the data so that you're not dealing with 8,000 pages of strips. And we can see here where the device or the rhythm returns to sinus and the device stops recording the rhythm. For this next episode, so this is 2 of 11, page 1 of 2, I did compress these 2 pages just to save on some slides. So obviously the device has limited storage ability. So when you have a bunch of these recordings, things are going to get overridden, and it's all, fastest, longest therapies, things like that, the device will triage what it saves. So this one, it did not record an EGM. It is telling us what the device saw. So it was basically seeing a non-sustained episode about 6 seconds long at a rate of 152 beats per minute. It's going to call everything that does not meet detection a non-sustained episode. So if you do see the EGM and you can tell that it's 1-to-1, then you know it's not a non-sustained VT, it's just an SVT. But obviously we can't see this EGM, so I'm just kind of showing you what is captured when some of the episodes start to get overwritten. Here's a similar one. This is episode 3 of 11. Again, 6 seconds, falling into VT1, 153 beats a minute, but we don't know what this one is. But again, even at 6 seconds, it would be non-sustained. Even if it was a real VT, it would still be considered non-sustained. Here's episode 4 of 11, kind of the same thing. I'm just going to keep through here. So now here is episode 5 of 11. So this one was 36 seconds long at 151 beats per minute. So we have an alert that the SVT discriminators disagree. So basically there are multiple discriminators in a device. So this one is going to fall under that VT1 zone. It did meet detection, but what the device is programmed at for VT diagnosis criteria is that only 2 of the 3 discriminators, so under morphology, sudden onset, or interval stability, which can be programmed either with a stability delta or a SIH count, which stands for sinus interval history count. It will tell you, it will compare these, and if 2 of 3 agree, then the device will either give therapy or in this case just tell you what it is. Typically in my territory for a single chamber ICD, we program these discriminators to if all. We want all of them to match. Now the difference, or the only exception to that, is if you have a patient who is pacemaker dependent. So if they are pacemaker dependent, we are not going to be able to score a morphology template because you're going to be you're going to only have a paced R wave. So the definition, of somebody who's dependent, if you do have a fast ventricular rate, it has to be SVT. I'm sorry, it has to be VT because they are not generating those waves on their own. There's nothing to compare a paced wave to. So just kind of keep that in mind. This is something I noted in my observations. And again, coming from this from the field, and then if I were looking at this in the office, I would obviously look to see if the patient is having or has had a history of these types of episodes and just kind of compare. Because then if we do bring this patient in for reprogramming, let's say they're having a lot of these and it's just kind of, causing a lot of recordings that we're not concerned about, we can reprogram this. But this one just kind of caught my eye here. So you can see this VT diagnosis criteria, and it says 2 of 3. So in this case, morphology tells us that it was SVT, sudden onset's telling us it was SVT, but this interval stability is saying that it's VT. So, again, is it perfect? I'm not sure. We will look at this. We will look at this recording, which looks awfully similar to the other ones that we've been seeing. So, if there were therapies programmed into this first VT1 zone, this patient could have received either ATP or a shock based on the discriminators, because it did say if 2 of 3 then deliver therapy. But we're kind of just clipping along, watching the same behavior around the same time. This particular episode. One thing I do want to point out as I was marching these through, I did see some signal dropouts. We can see this here. So I believe our R waves, I'd have to go back to the fast path, but I believe they're measuring right around 5 millivolts. So I do notice some undersensing in some of these recordings. Just pointing it out, it's obviously not happening a lot, but when we're talking about VT or VF, we don't want to be missing any signals. So just something to kind of put on your radar there. And then here's the end of this episode. Again, no therapies, it just returned to sinus. And you can see that the morphology looks so similar on this episode as well. Here's our next recording. So this is episode 6 of 11. This one again, right around that same time, 4:13 p.m., right around the same rate of 155 beats per minute. And this one was 2 minutes, 26 seconds. The duration again is over 1 minute, and we are being told that our SVT discriminators disagree. So initial diagnosis when this rhythm started at 4:13 p.m. was SVT. We can see here that two out of the three are saying that this was SVT, but once the diagnosis was made, it indicated that VT was what the rhythm was. So SVT discriminator for morphology was consistent, but then sudden onset was indicating VT, which it did in the initial diagnosis. But then if we look at the stability delta, the initial diagnosis showed that that was SVT, and then the final diagnosis says that it was VT. The SIH count, which you can program either one of these on, that one's programmed to passive, is also indicating VT. So again, we definitely prefer programming if all. We want all three of these to match if the device is going to give therapy. Again, this is going to be something you want to discuss with your physicians, but if a therapy zone was active, this patient could have very well been shocked for this rhythm, which seems like it probably isn't true VT. Again, I'm not an EP, but just looking at this and from my experience, these all look the same. It could just be SVT with aberrancy. That's why some of the morphology is not matching up perfectly, but definitely doesn't look like it would be a shockable rhythm. Obviously, we would want to see how the patient is feeling and if they have a history of this, but I'm just taking a guess here. So keep scrolling through here. So here's where it was saying it was SVT, and then here's where it changed. So it looks like it potentially switched a little bit. We're just monitoring it in VT. We can see a mix here of this X'd out binning, which is saying that, hey, this morphology does not match our normal sinus intrinsic morphology. These do, but then this one doesn't. This one does, these two don't. So it's kind of bouncing all over the place. And again, I am seeing some variation in these rates. We have 355, 383. We have a 406 down here. It's just kind of a lot to look at, but it is good practice to poke through. And then we continue on. This is page 5 of 6. Again, some more of that stitching because this was a longer episode. We can wrap it up here, and this patient apparently just returns to sinus. So we will look at the next one. Here's episode 7 of 11. This one is calling this this recording VT1. Again, just a few minutes past when this whole thing started. This duration was 5 minutes, 6 seconds, again over 1 minute. And again, it's telling us that our SVT discriminators disagree. So monitor only, initial diagnostic summary says this is SVT. But then we kind of switch over and it says, nope, I've decided that this is actually VT. So met detection. Morphology, sudden onset, and interval stability were all applied. Initially, these first two said, yes, this is SVT, but then our interval stability says, nope, this looks like VT to me. So the device then says, okay, morphology still looks like SVT, but these other two, this max delta for the sudden onset and interval stability, are showing VT. So we're going to say that these disagree, but again, this is 2 out of 3. So there are no therapies programmed in here, but again, these rhythms just look so I think some of these rates are just kind of falling right in those that delta, which also is programmable, on that interval stability. So it just is not allowing enough wiggle room, or maybe a little bit too much, in order to say, yes, this is SVT. So scrolling through here, all looks the same. Again, curious because it was all around the same time as well. I'd be really curious to see if this patient has had a history of this and if this is normal for them. Okay, we'll just keep going. So I was thinking it was SVT here, and then it says, nope, this guy sped up. Things started looking different. The interval stability was a little bit different, so we're actually going to call this VT. The other thing here, you can see another signal dropout. But again, it's kind of wobbly, 410, 418, 352. There definitely are some fluctuations between these beats. We're going to continue on here. Same thing here, another signal dropout there. And we slow down a little bit and then return to sinus. So I looked ahead, and we're getting towards the tail end of these episodes. So here's 8 of 11. I'm just going to kind of click through these because they do look very similar to the others. Again, I combined these 2 pages just to show no EGM was available, but we have a non-sustained. Would you include all of this in a report to your physician? Potentially. It all depends on your physician preference. I typically would not, but I've been doing this a little bit longer. So for practice, it's always okay to include things. Just try to be super specific about, what it is and why you are including it. So I'm going to kind of go through this. So here was another one saying that it was in the VT1. Our SVT discriminators disagree again, and this is actually calling this a bigeminal rhythm. So it is no longer calling this VT1. It's saying that diagnosis was aborted. So a little bit confusing here. Again, a lot going on with these discriminators. 2 of 3 again, but sudden onset shows SVT, but again, no therapy is delivered. Going. Here are these EGMs. Again, signal dropout there. Gonna scroll through again. It all looks the same. So I'll jump on here. Here's episode 10 of 11. Again, SVT discriminators disagree. It is calling this one SVT. So this is a little bit slower than the others. This is around 150 beats per minute. Initial diagnosis and actual diagnosis say SVT. And here we can see that the morphology says it's SVT, our sudden onset says it's SVT, but then when we look at interval stability, this stability delta at 35 milliseconds indicates VT, but this other one is saying that it's SVT. So definitely interesting how these have differed a little bit in between the recordings. Let's kind of keep an eye on that. Go to this next page. Again, more of the same. And here we are where we terminated, or spontaneously terminated. So here is episode 11 of 11. This one's calling this one VT again. This was the next day. So this one was at 151 beats per minute. 30 seconds. Our SVT discriminators disagree. And again, it's giving this note that it was a bigeminal rhythm and that the VT1 diagnosis was aborted. We can see how our discriminators played in here. Morphology was indicating VT. Sudden onset says nope, this is SVT. Interval stability is giving us a diagnosis of VT. So kind of a lot going on there. Some of these can be very confusing, especially when they're disagreeing. But again, you get to know your patients and their history and what some of their rhythms look like. And then you start either reprogramming or running it by the physician to see what's best to manage these transmissions that are coming through. So here is that EGM. So we can see it kind of started a little bit slow, and you can see it speed up here. It's kind of going beat by beat, some definite morphology matches and a lot that are not matching. But then you have these occasionally that pop in here that show SVT. So see how it just varies. But again, it looks just like the other episodes. So we're just kind of monitoring, and then it terminates on its own. So we've looked at all the episode slides. So now this is giving just an episode morphology template update. So this is showing you how it is scoring the intrinsic wave. And you can see here, it's actually saying, it's giving it an X here. So this is not matching what a normal sinus beat would be. So that was kind of interesting. And then these down here do. So just like in those other recordings, the deflection looks real similar. It looks pretty narrow. And even in this morphology update, it's looking just like those other episodes, just kind of varying. So here we jump into some more extended diagnostics, just more information. So again, pacing percentages, ventricular heart rate histograms. We can see that it's pretty regular, well distributed. You can see these kind of short, fast rates down towards the higher, 130 through 210, but definitely nothing that is sustained. And this just shows our exercise trend as well. So here we're showing a max heart rate of 190. So we do see that this patient has days where they're absolutely more active than other days. So I'd be really curious to see, do these episodes that were recorded, are they falling in the same time that this patient is being active? So again, getting to know your patients and finding out if things correlate before we get super worried that, they're going to receive inappropriate therapy. We have more extended diagnostics here. Again, just showing total daily activity totals. Again, there are some days where this patient isn't super active and others where they are. And then our core view impedance monitoring trend, this is a 3-month view. We can show for the past 3 months, there have been no status days, meaning it does not appear that this patient is having any sort of fluid accumulation or buildup. This is another snapshot, but this is our direct trend 1 year daily sort of snapshot of different things like our daily pacing percent, which we can see has been consistently slow or low, I'm sorry. Daily heart rate, day and night. We can see this fluctuation here, daily activity, and this is again graphed over 1 year. And if we look at core view for the past year, looks very stable except for this period of time here. So it was in between July August. It looks like around August, and here's September here. So it shows we did have some impedance status days that showed possible congestion. Again, it's a representation. It doesn't necessarily mean that the patient is retaining fluid. It's just kind of a nice jumping off point. I usually, if I'm interrogating somebody or if I get a report that shows, this type of bar at the time that I am looking at the report, I will flag it to the physician and just say, core view shows possible fluid accumulation. If the patient says that they are having increased shortness of breath, I'll make a note about that. Otherwise, I will say, patient denies symptoms. You can also state that core view appears to be stable. That's if you do not see any sort of impedance status days. This is just our ventricular sense test. These are always nice to look at for trends. So it does look like our R waves have dipped a little bit over the past year. I mean, it's still within range. Sometimes they do start off a little higher and then they can settle in a bit, but just something to kind of watch. And then here is the actual sense test, which is measuring the amplitude of the waves. And we do see some variations here, like this one's 3.9 millivolts, all the way up to 7. So just ways to look at trends. Scroll through here. This is our lead impedance and battery. So this is our ventricular lead monitoring, and it is very stable. This is exactly what we want to see. We don't want to see, things trending up or things trending down. That can be a sign that the wire may be having an insulation breach or starting to break, maybe a fracture. So that's why we look at the impedance trends. And then on our high voltage devices, you are going to get a high voltage lead impedance trend as well. So again, what we are looking for is stability, and that is exactly what we are seeing. So for our battery information, we are showing 7 years. We show a max charge of 9.5 seconds, and then our battery current, and then our remaining capacity to the elective replacement interval. So it's showing 78% at this point. So 78% capacity with 7 years. Because the Abbott devices do not read out in a voltage, when I am reporting this on a report, I will put 7 years / 78% capacity. Some physicians want the charge time. So again, it's just physician preference on what information you include. It's always a good idea to keep a updated set of parameters. I noticed in this device they did include the ejection fraction of 15%. Our indications are dilated cardiomyopathy. And we can see that this is a pretty young patient, this 1990 year of birth. And I actually just noticed that as I was combing through this. So again, when we're looking at those episodes when that patient's heart rate was in the 150s, given that they are a younger patient and then we saw those spikes in exercise, I am willing to bet that those rates are happening when that patient is exercising. So always good, as I mentioned, to keep updated parameters. I always go back and reference them just in case I need to make any changes on the device. Never hurts to save anything. And then here is a little bit more detail on how the zones are configured. So this becomes important when we talk about other ways to consider maybe more appropriate programming for this gentleman or female. I'm not sure if it's male or female, but we can see here our VT1 zone. The detection criteria is 150 beats per minute. There need to be 18 intervals before the rhythm meets detection. We show that our SVT discriminators are on, but therapies are off here. We are just simply counting. When we look at VT2, that zone starts at 200 beats per minute. We have 16 intervals, same discriminators are on. And if you look at the shocks, we have the first shock at 25 joules, the next one at 36, and then the final two at max of 40 joules. This device can deliver a 40 joule shock, but it does need to deliver a 36 before it can do that. What's interesting is this third zone shows ATP while charging, but then it goes to a 34 joule shock and then 240. So I wonder if that was intentional. I would say most of the time, at least in the area that I work, we max out the shocks. That is, of course, unless your providers are doing very specific DFT testing, or if this is just their preference. Everybody's different. But if I were to see this, it's a little suspicious to me that there's a 25 joule shock first. And then this 34, that's definitely some intentional programming. I thought that was kind of interesting. But typically we would just max it out. A 25 joule shock is not going to feel any different than a 40 joule shock. So, and here we can see our VF zone at 222 beats per minute, and the number of intervals for detection is 12. So you will also see here that the SVT discrimination is not on. You cannot turn on SVT discrimination in the VF zone. There is no discrimination in the VF zone. So if that rate is reaching 222 beats per minute for 12 intervals, the device is going to go to therapy. It's going to first try to anti-tachycardial pace while it charges up. If that does not terminate the rhythm, it is going to go to a shock. So it will go 34 in this case, then 40, and then another 40, 4 more times. So just remember, there is no discrimination in the VF zone. Here we are with, just our discriminators again, and here where I was talking about how it's programmed. If 2 of the 3 of the active SVT discrimination criteria indicate VT, then you want to deliver therapy. Again, that only applies if your zone is programmed to deliver therapy, which, as we can see here, all of those episodes were right in this VT1, so that wasn't going to happen. Here are more parameters. So these are our ATP details. So this is just the scheme of the ATP. So anti-tachycardial pacing, there is so much programmability within this particular setting. You can adjust the number of bursts, you can adjust the number of stimuli within those bursts, you can adjust how fast it's given, you can make it adapt to the current rhythm and redetection and then change how it delivers those schemes. You can turn on scan, you can also turn on ramp. So those two features are increasing the burst cycle length between burst or within the burst. So we'll get into more detail in that down the line, but we can definitely see that there is all kinds of programmability within here. I would say the most common is probably the pain-free programming. If we do not have to shock a patient, we don't want to. So that's where ATP comes in, and it's based on a specific trial, which we can get into down the line. If we look at the VF zone, there is ATP while charging, but one of the only things you can change in here is, how you can only deliver one there. That's what I'm trying to say. And you can also change, which I always go in and change, is this limit here. So this is saying that it will only try to give ATP if the rate is under 250 beats per minute. I actually changed this, I have for the past 8 years, to up to 300 beats per minute. I have not seen it hurt anything, and it just gives that last burst attempt a good shot of terminating that rhythm so that the patient doesn't have to be shocked. So these sensibility settings, moving on here, just talk about how the device senses the signal. So I've said this before, but the most important thing the device does is sense. That's true for a pacemaker, and that's true for a defibrillator. So our defibrillators have very special sensing parameters because we're dealing with potentially very small fib waves. So you will see specific settings for the pacing and specific settings for the defib. These I never change unless I have a directive from our technical services. So typically I would come into these parameters and make a programming change. Let's say I was seeing some non-sustained RV oversensing or some T-wave oversensing. What I would do is call into Abbott. I would ask them to look this patient up. It's easiest if the patient is on remote monitoring. You can actually have the engineer pull up the remote monitoring reports, and then they can take some measurements, and then they can recommend if you would need to adjust any of the settings within sensibility settings. Anytime any of these are adjusted or changed, they do recommend that the physician do DFT testing, meaning to induce fib and shock the patient out of it through the device. Again, because the sensing is the most important thing the device does. And if we start to adjust that, we just need to make sure that we're going to be able to see everything. This is our depth response, defibrillation threshold response settings, our shock waveform. This is just how that shock waveform is programmed. I rarely change these. It would have to be something very specific. And then we have, or I should say, Abbott has a special algorithm where you can actually what we call tune the waveform. Again, that's not something you would do in clinic, but just something to kind of be aware of. If a waveform is tuned, you will see high voltage therapies listed out in volts, not joules. So just kind of a little extra information there. It is specific to Abbott, and I'm sure we'll talk about that down the line. All right, so looking here, page 4 of our parameters, again, this is just breaking down a little bit more of the nitty-gritty here with ICDs. These are always longer sets of parameters because there are so many different things to consider. So this is our post-shock pacing mode, our base rate. Notice how it goes from 40 during, normal lower rate limit settings, but if a patient were to be shocked, it is going to temporarily start pacing them at 60 for a certain amount of time. If a patient is shocked, it is going to give at least a 2-second pause before it starts pacing or starts sending a pacing impulse. That's just so we're not pacing into any sort of like T-wave or anything like that. This would be redetection and post-detection. So this is just saying if after therapy is delivered, the device will redetect and it will need 6 intervals within that VT rate in order to say, hey, we're back in this rhythm still. So these are programmable, again, only changed if tech services recommends them. I've only changed them a handful of times over the years, but I did want to point out what they are. This is our capacitor maintenance, so the charge interval is going to be every 4 months. It's going to test itself. MRI mode, pacing is going to be off, and then it's asking what type of high voltage lead it is. In this case, it's a dual coil lead, meaning it has a coil in the SVC as well as one in the RV. And then we can see our core view monitoring is turned on and the threshold is 14 days. So it has to have an impedance range under the reference range for 14 days in order to call it a status alert. These are more triggers. So you can have different things show on a FastPath summary. For example, a lead impedance being out of range. You can have that show on FastPath. You can also have it notify the patient. So every device is a little different. This particular ICD will give a vibratory alert. So, it's just important to remind patients that their device does have this, even though I have rarely seen devices vibrate for most of these reasons, I do like to educate the patient on the vibratory alert, especially if they are nearing the elective replacement interval. That's probably the most common reason why a patient notifier would be delivered. The patient notifier delivery can also be programmed. If you recall, or if you've been in the industry for a while, or in the space for a while, there have been recalls or advisory devices. And one of the things that we were doing when that first advisory came out was that we were extending the vibration duration, we were extending how many notifications, and we were shortening the time between the notifications. That way, if there was a premature failure, we really wanted to make sure that patient was going to feel it. The downside of this vibratory alert on this device is that if a patient does not know that it can vibrate, it can absolutely scare the heck out of them. So I really do try to educate patients. I don't just automatically jump in and demonstrate it for them. I ask. You have to remember these are ICD patients, and if they've had therapy, sometimes they can have a little PTSD, and any sort of feeling, or even if you tell them that you're speeding up their heart rate during a threshold test, it can actually kind of trigger them a little bit. So I always ask, and I also give the option if they don't want me to do it at this check, think about it. Next time they come in 3 months or 6 months, if they'd like me to demonstrate it for them, I can. I just really stress that it doesn't mean that there's something wrong with their device. It just means that, the device is trying to say, hey, have me checked. I'm seeing something and I just want to be checked out. And then you can demonstrate it for them at that time. I've just checked many patients over the years who have gone to the emergency room because they didn't know that their device could do that. So I try really hard to keep the patients educated. Here you can, customize episode triggers. So if you're getting a lot of, let's say, magnet responses, or you don't want these morphology templates, you can certainly turn those off. You can also go into your stored EGM configuration. One thing I like to do is on this pre-trigger, I like to go to 20 seconds. I really want to see how a episode starts. I think that's super important. Is it a PVC that's kicking off something, or what is it that is triggering that episode? So I will change this. It is nominally 14 seconds. Oftentimes I do change that to 20 seconds. We have a total of 45 minutes worth of storage, and this particular device only is storing one EGM configuration, which is fine because it just has the one wire, and it is in the ventricular sense amp. I do recommend you leave this as sense amp because some of the things I mentioned earlier in regards to non-sustained RV over sensing, or if you need help with technical services, making a measurement or getting you a measurement for any sort of change, this is the configuration that they need to see. SenseAmp is what the device sees. So if you just leave it programmed SenseAmp, it will help down the line if you do need to do any further troubleshooting. We have finally made it to the end of this report. This is just the wrap-up summary, again, showing that there was an alert. We know what those were for now. This is going to give you any of the automatic tests that were run. Again, because the ventricular capture threshold cap confirm is off, we are not getting a threshold here. I typically, on a side note, leave that off for a non-dependent patient. Actually, I kind of have different philosophies for different types of patients, but if you have somebody that's not going to be pacing, I don't want an automatic test that's kicking on and pacing them in the ventricle happening for them. I'd rather just have a nice set fixed output and not have to worry about them potentially feeling ventricular pacing every 8 or 24 hours. This is going to give us our sensing measurement, our lead impedances. It all looks good. Mode, therapy zones, and of course no programming changes made because we cannot change programming through our home monitor. So I'm just going to over here. So if I were the one writing up this report, I would obviously include device information, things like that. Every report's a little bit different. Depending on, if these are common for this patient, would you even put this in the chart? It is all clinic specific. So just make sure you guys have good practices and know what your physicians expect from these transmissions. But obviously it's a single chamber ICD with one alert for VTVF via Merlin.net home monitoring. So the alert is for 11 total episodes recorded. I kind of break out what the device is calling them. I like to put device diagnosed because I am not the one diagnosing this. I can only tell you what the device is seeing. Obviously, I can recognize rhythms, but I'm not a physician, and unless you are, I'd be really careful with your wording unless you are absolutely sure. So I like the terminology device diagnosed, non-sustained for device diagnosed, VT, and I put them in quotation marks because that's what the device is calling them, but is that what they really are? And then 3, device diagnosed, SVT. So I put all episodes are in the VT monitor zone, and there are no therapies that were delivered for any of these episodes. All right, the 10 of the 11 were all on the same day within the same hour and 25 minutes. The longest was 5 minutes, 6 seconds at an average rate of 162 beats per minute. SVT discriminators disagree on some of the recordings, but the episodes all look very similar, and always see EGMs for confirmation. Battery capacity is 78% with approximately 7 years remaining. Our ventricular pacing is less than 1%. Core view appears to be stable. And then just for kind of advanced programming here or advanced consideration, the more familiar you get with these device checks, and if you are doing your own programming, this would be one I would potentially discuss with a physician, especially if you're getting lots of transmissions from this patient. If they're all looking the same, what can you change? You can change the monitor zone. You can take it from 150, maybe take it up to 164 if that's appropriate. It's all dependent on what your physician wants. But if you were to change that, it would just stop triggering those transmissions. You can also increase the number of intervals. I have seen these out to 100. I've seen them out pretty far. So again, you would discuss that with your physician. I would consider matching the discriminators from if 2 of 3 to if all, if your physician finds that to be appropriate. We do not want patients getting shocked for the wrong reasons. And again, I marked that I did note some undersensing, and I pointed one out very specifically, episode 5, page 3, 39-second mark. So a little bit more detail here. Again, this is just if I were going to be writing this up, I don't even know if I would end up showing this to the physician. Now, if I had a patient call in and say, hey, I was feeling really terrible around this time, did anything happen? Okay, well, maybe we need to look at it a little bit differently. It's just my guess is that this patient was probably exercising during that time.